as we go forward. All right, so we started in chapter 1 on Monday. What kind of questions do you have for me on material or on your worksheet that I gave you? Any questions yet? Yes, ma'am.
In a work setting, professionals use the generic name?
Yes. Yeah. So nurses most often will use the generic name. So this is one of the things. So a little bit about some of the things that I do. One of the things that I do is I am a site surveyor for other technician programs. So I go to other programs and I see if they meet the requirements. And my primary person that I go with is dean and faculty academics with University of Texas in Austin Pharmacy School. So she's a pharmacist, and I always sit and hit the button, making sure I hit the button. So she mentioned at one of our last site visits, pharmacists never learn the brand names of drugs. They only learn the generic names of drugs, which makes techs better in the field at identifying those medications. Because our patients will most often use the brand name. And your pharmacists and your nurses and your doctors are most often going to use a generic name. Well, your doctors use a lot of brand names. But yeah, so the healthcare professionals primarily know the generic name. Good question. What else? That's why we have to know both. That's why you suffered through 103, right?
I have a question, but it's not about the class.
Okay.
So we were talking about like a private pharmacy,
Okay. You mean like a closed door or an independent?
like an independent,
Okay.
and then the big chain ones like one.
Consideration about pay. It'll depend on where you are. It'll depend on what they do. If it's an independent pharmacy that does not do compounding and it's family run, they may not be able to afford to pay a lot. But it doesn't mean that it's not a valuable place to work, because a lot of times those are very family oriented. You work Monday through Friday, maybe half a day on Saturday, once a month kind of thing. So scheduling could be a trade-off. Community pharmacy, New Orleans is an odd, in Louisiana in general, it's kind of an oddity comparatively to other types of pharmacies, in that they, generally speaking, hospitals pay less than retail for community. But I've heard people tell me that hospitals are coming up. I don't know that I've seen it. And then there's other things outside your traditional community and hospital. There's a lot. So I got a phone call this morning from one of the students who finished this summer, who got a job offer at a hospital and thought they'd be working PRN, a part-time position, in the inpatient pharmacy, and actually they offered her a position as an ED tech. So she goes and takes patient histories, which brings her in at a higher salary, a much higher salary. She just finished. But she did her clinicals there. They were impressed with her work, and they want to cross-train her, which means, she's got a lot of opportunities. I have another one who's having an interview today that's, it's kind of a formality, is going to be hired into specialty, which is kind of a community type setting. Again, a fresh grad doesn't usually walk into that job and will make probably anywhere from $14 to $18 an hour just walking in. So, just walking in. Like finishing our program and getting into that higher level job. So instead of starting at $11 or $12 an hour, they're starting in both of those positions somewhere between $14 and $18 an hour. So it's hard to say what opportunities will be there for you.
You just gotta do good on your clinical.
Do good on your clinical. That's key. Yep.
And how many? That's 600 hours.
No. distracted very easily. So, with the change of the law in January, prior to January, if you got a permit from the state board to train, you had to do 600 training hours. January 1st, the law changed. There's now 3 ways to become a technician in Louisiana. One is you're in an accredited program. You do your application. I provide a letter that says that you're in a program, and you get the permit. The other is you're certified and worked for a year. And then you have to come to Louisiana and do training hours if you come from outside. And I forget how the third one works. It's if you come from another state, then you do, I think. So, with the new law, once you're in our program, there's no additional training hours that are outlined. It just says the number of hours required by the accredited program. So through accreditation, we're required to have a certain number of training hours that we call experiential hours. So we break down your learning into 3 different categories. There's didactic, which means classroom, traditional learning. There's simulation, which is your labs, and experiential, which is your clinicals. So accreditation has a specific number of training hours required for that experiential. And then I also have a couple hundred hours to spread out over all 3 of those areas as I see are pertinent. So currently, you guys, they say you have to do a minimum of 160 hours in one practice setting. Well, that's not our program. Our program has you doing 160 hours in each practice setting. So you get 320 training hours. So you're going to be out there for 10 weeks, and you're going to do 32 hours a week. So your clinicals, if you do clinicals in the summer, it's different than the fall or the spring. In the fall and spring, your clinicals are Monday through Thursday for 8.5 hours a day, because you can't count your lunch. It's like a job. And Friday is when you come and do exam review, and then if you need to make up hours on Friday or you've got another job kind of thing, Friday, Saturday, Sunday type of thing. In the summer, because we're not open on Fridays, we meet on Monday for exam review, and you do your clinicals Tuesday through Friday. So it's still 4 days a week, just different days. Which means that even though the school's closed on Friday, doesn't mean I'm not working and maybe doing site visits and tracking me all down. I will show up. And I like to stand back, like where all the medicines are on the side, in the rows, in the aisles, and watch in the mirrors, on the videos, and see how long before you even realize. Or somebody, the other thing is, too many people know me and they give me away. Oh, your teacher's here! I'm not supposed to do that. But. Good questions, even though not part of the lecture, but good information, important information. So, any other questions? General questions? All right, back to the lecture questions. All right, so any questions so far on what we covered the other day? General knowledge so far. All right, so we started talking about nomenclature, right? Is this where we left off? It appears, we did the name that drug. Which should have been familiar if you did 103. All right, so nomenclature, drug stems. So when you learn medical terminology, they call it word parts, right? So different things that kind of tell you what that word means. Hepato means what? Liver. Itis. Inflammation. So we use these pieces to help us identify. So in pharmacology, we use what's called a drug stem. So it helps us identify the pharmaceutical class of a drug. And we're going to talk a little bit about what's the difference between a therapeutic class and a pharmaceutical class, but we'll come back to that part. So stems could be a prefix. They could be in the front of a drug name, like sulfa. So sulfamethoxazole, well, if it starts with a sulfa, it tells us, oh, it's a sulfa drug. If patients are allergic to sulfonamides, they shouldn't take this medicine. Or other things that my brain says, in my spider web of knowledge, when I hear sulfa, my brain starts ticking. Okay, don't take it if you're allergic. Drink lots of fluid. It can cause crystalluria. It also causes photosensitivity. Doesn't matter what the drug is. I don't know what the drug is. Well, in this case, it's an antibiotic. But because I know those about sulfa drugs, I already have that checklist. So no matter what the sulfa drug is, I'm looking for some of that information when I'm doing my patient profile. Do they know? Drink lots of water. It could be an infix. It could be nestled in the center of the drug generic name that identifies it. So pred, now there's two parts here. I see one that's in the middle, and I also see a suffix, Salone. So one, it tells me it's related to prednisone, and the Salone tells me it's a corticosteroid. So I'm seeing two things there. And then the last, of course, being a suffix, Cillin. And most of our drug stems will be a suffix. So Cillin means that it's in a group of penicillin. Penicillin, amoxicillin, ampicillin, piperacillin, piperacillin, nafcillin, oxacillin. There's a whole family. Well, what do I know about Cillins? Oh, okay. Usual side effects cause diarrhea. Women will generally get a yeast infection. Can be taken orally, can be given by injection, used for sinus infection. You know, my brain takes off the things I know about them, what they have in common. So we will use drug stems. Now, y'all took 108. We're not going to spend a whole lot of time belaboring law in pharmacology. But a couple of things that do relate to pharmacology. The Pure Food and Drug Act in 1906, its intention was to protect the public. It didn't really make its goal. That had to be done later. It just said whatever's in this bottle has to be on the label. You can't put something in here that you didn't tell me was in here. And things built from there. The Durham-Humphrey Amendment in pharmacology helps identify how we have accessibility to medications. So the Durham-Humphrey Amendment identified medications that needed a prescription, so what we call a legend drug. And then that, if it didn't require a prescription, now becomes over-the-counter. So that's the importance of the Durham-Humphrey Amendment. Now we've had a lot of changes since that time in medications that fall into a different area. They're over-the-counter, but you can't get them, you know, type of thing, with your restricted or your behind-the-counter drugs. The FA18 Amendment requires the drugs to be safe and effective. So it took from 1906 to 1962 to close all of the loopholes. There were many legislations in there that kept trying to close loopholes, but they kept forgetting to add a piece. So the Pure Food Drug Act, it's pure, it's got the list. Then they had to make it, okay, it needs to be safe. You can't put poison in there. Oh, wait, it's safe, but it doesn't do anything. Okay, now it needs to be effective. And that's where the FA18 Amendment came in. So the safety issue was addressed previously, but we could sell drugs that didn't do you any good until this kind of came into being. That also started the whole drug research and the clinical trials and all that kind of stuff to make sure that it's safe and effective, and we're getting the best treatment for our patients. The Drug Price Competition Act and Patent Restoration Act in 1984 helped with the encouragement of generic drugs, which started savings for our patients in our hospitals. Generally, hospitals purchase generic drugs. So that's another reason that we have to know the generic name. In your healthcare setting, that may be all that's available. And that's why we need those ED techs. Like how I segued our previous conversation. So the people who work community know a lot of the brand names because that's what your patients know. So when your patient comes into the emergency room and you say, well, what's your list of medications? They're going to tell you all the brand names. But if you work back in the pharmacy in our little unknown hobbit home, usually in the basement of most places with no windows. Nobody knows what we do in the pharmacy. It's a big secret. Only pharmacy people know what's going on in there. If you're dealing with generics all the time, you might not know for any of that. So that's where the ED tech brings those two worlds together. So generic drugs, and then we have behind-the-counter drugs. So it helps certain things. There's no prescription, but there's limited access. A couple of years ago, and your book talks about it because it was printed before the law changed Plan B. Plan B now is completely out OTC. It's not restricted. But we have things like ephedrine and pseudoephedrine and those types of medications that require access through the pharmacy to get the medication, even though you don't require a prescription. You're limited as to how many units you can purchase at any time or through a month or things like that. Most of those are also connected through an electronic record-keeping process. When this process first started, everything was paper controlled. So they could go to Walgreens and then go across the street. And unless somebody pulled all the records and audited everything, the people never got caught. Well, now everything's electronic. You have to swipe your ID, and they know, hey, you bought whatever. Yeah, something with pseudoephedrine. I was last year, I was eating some Broncaid because I was having some respiratory issues or some Mucinex or something. And I was behind this poor woman who was suffering really bad with allergies and like really congested. And she was trying to buy some like Claritin D or Sudafed or something. And they're like, we can't, you just purchased, well, she picked up a prescription for her child that had one of those ingredients in it. And because it was on her ID, and luckily she was pretty understanding about it, but my heart kind of felt for her a little bit on that moment. But, and I'll be honest, the first tech that dealt with her did not handle it well. It was just kind of, and somebody else came over and helped her, and because I'm standing there and I'm like, please do not be talking to a patient like that. And when the other one came over and they actually looked at the profile and looked at what she picked up, they were able to explain it to her. Because most of the time, if you can explain it and not just like dismiss people, they're usually okay. So that leads us to the Combat Methamphetamine Act of 2005, or the CMEA, to stop people from buying copious amounts of pseudoephedrine, which can be chemically altered and changed into crystal meth, and then some other drugs have fallen into that group. And in fact, some pharmacies have stopped selling just because they don't want to deal with it for some of these medications. The Controlled Substance Act, which is actually the Comprehensive Drug Abuse Prevention and Control Act from 1970, came about because of the late 1960s and all the crazy drugs that were going on between 67 and 69, regulates controlled substances. So category 1 through 5. So Louisiana is in an interesting place right now. We now allow medical marijuana. And we will have 8 or 9 dispensaries. They're not called pharmacies. They're dispensaries that are approved by the State Board of Pharmacy. So Rustin Henry, who owns A2W Drugs, it's a 50-year family-run pharmacy in the city, is the person who was selected to do the one for this region. The state's divided into several regions. Now, the interesting thing, and I found this out from the state board last week, people can't get a prescription to go get medical marijuana. It can't be prescribed because it's a C1. It's not available for prescription use. However, because it's approved by the state, they can get a recommendation from a designated physician who has the authority to give this recommendation. Now, I don't know what a recommendation looks like. I'm interested to see, does it look like a pharmacy pad, like a prescription pad? What does it look like, kind of thing? I just thought that was pretty interesting.
So it's only certain doctors that
certain doctors, certain providers will have the authorization to be able to recommend. And if you go to your general practitioner and they're not on the list, they can't tell you to go. And the pharmacy won't, or the dispensary will not give it to you.
I've never seen that on the news. That's in Metairie?
It's on Paris Road in Gentilly, actually. So yeah, pretty interesting. So that's a whole other thing. Now, as a technician, potentially you could work at a dispensary. It's on a state board site, but you have to be a technician for a minimum of 1 year. Not on your permit, not anything. So that's kind of smart on the state board. We don't want people just trying to become a tech to go work at a dispensary kind of thing. And then we're not going to worry about the Controlled Substance Act in Canada. We're not close enough to worry. If I was in New York, it may be a different thing. The person who writes this book, I think they're from Michigan, so they're not from Canada. So, all right. So the next topic is drug dosage forms and delivery systems. You're going to talk about this in pharmacy practice because when we talk about drug dosage forms, they can't be interchanged. It's a doctor's call. When they say they want a tablet, that's what we give the patient. If we don't have the tablet, the capsule may not work the same way the tablet does. Some things they do pretty well, and it takes a phone call. Or, syrups and things like that. So understanding what the delivery systems are. So part of it is the route of administration. So we can have medications that are delivered orally, taken by mouth, that are given parenterally through an injection. Pretty much anything that's outside of the GI system is parenteral. But we kind of use that term when we mean injection. But even inhalation is parenteral. Bless you. So inhalation, that could be into your lungs. Maybe if you have asthma or COPD. Breathing in a drug that's going to work right there. Or it could be nasal inhalation. And then topicals. It could be something that's applied to the skin or the mucous membrane. So it could be a transdermal patch, it could be a cream, it could be an ointment, it could be a gel, it could be a spray in your nose. If you have allergies, that could be considered topical. Allergies. Inflammation as a steroid, it would decrease the inflammation. And then there'd be some absorption as well. So absorbed through a mucous membrane. Factors that can affect our choice, the chemical properties of the drug. Some things we can't give by IV. Okay? If it's going to be in an IV form, it has to be a solution. It has to be generally isotonic, at least when it's put into some kind of solution, it would be isotonic. Oops, go back. Solid, liquid, gas. Is it a base? Is it a acid? What is it? And then our body's physiology can also have an impact on what we pick and why we pick it. Also, think about the state your patient's in. Okay, if they're vomiting, we may not be able to give them something oral because by the time they get it in their stomach, it's going to come back up and it's not going to have done any good. Or if they're unconscious, you can't put it in their mouth and massage their throat to get them to swallow it. So there's a lot of different things that go on. So enteral oral forms include tablets, and then there's all different kinds of tablets. We have delayed action, immediate release, we have enteric coated, sustained release, time release, film coated, sugar coated. Film coated and sugar coated generally don't really do much to the tablet itself, other than maybe make it a little easier for the patient. So think about an aspirin tablet, right? If you take a regular aspirin tablet, it could even start dissolving in your mouth. But if you take something with a film coating, it helps it slide down a little bit easier, and it doesn't start dissolving right away. Enteric coated is going to protect the contents of what's in that tablet till it gets to your intestine. There are certain chemical properties to an enteric coated tablet that get it starting to dissolve and absorb in your intestine and not your stomach. So they all do have some kind of reasoning. So we can't substitute an immediate release medication with an extended release medication or an enteric-coated medication. Other types of tablets, chewable. If something is chewable, many times it has to be chewed to be active. Sublingual, where's that go? Under your tongue. ODTs, orally dissolving tablets, or disintegrating. Those may be placed on your tongue or under your tongue. Migraine medicines come that way. Anti-nausea medicines come that way. Again, if somebody's vomiting, they can't swallow a tablet, but if you put it on their tongue and it dissolves and gets into their bloodstream, well, then you get benefit. Troches and lozenges, thin films. The films are kind of not taken off. They started a few years back, but I think humidity plays a big role in the success of that. Then we have capsules. Capsules are going to be either a hard gelatin, like the picture here, or it's going to be a soft gelatin, which usually has a liquid filling. Vitamin E, Robitussin, there's a few different ones that have the soft capsule. You might be able to see the contents in a hard capsule, or maybe you can't. It's powder. They're going to dissolve pretty quickly. As they get into your body, that gelatin starts to break down, so capsules can be a little bit quicker than certain tablets. Liquids, we have suspensions, syrups, elixirs, tinctures, emulsions. You're going to learn a lot more about those in PHaR Prac. I'm not going to spend a whole lot of time. Topical administration, ointments, creams, hydrogels, suppositories. Now, some suppositories are systemic absorption and some are meant for topical absorption. You've got, for women, if there's a yeast infection and they use a vaginal suppository, it's treating the infection at the site. That would be considered topical. Hemorrhoids. It reduces the inflammation at the site. That's considered topical. However, if it contains a narcotic or a pain reliever, that would be systemic because it would absorb through the mucous membrane into the blood system and go to the whole body. Transdermal patches are considered topical, but most of them are going to be systemic medications. Most of them are going to absorb through the skin into the bloodstream and do something systemically. So we have drugs to treat angina, like nitroglycerin. We have nicotine patches for people who are smoking. Those are going to absorb birth control, hormone replacement. There's a number of different types of patches. But then we do have some patches that are only local. We have lidocaine patches, people who have shingles. It's very painful. They can put a patch right on that area that hurts. So it's kind of like suppositories and patches kind of invert their information. The patches usually absorb and some are used topically, and the suppositories, most are used topically and some absorb. And then we have parenteral. So like I said, injectable. Oh my goodness, injectables. Well, we have a whole class for that. Sterile compounding, next semester. Where are we going to inject it? We can put it into a blood vessel, intravenous, intraarterial. We can put it into your muscle, intramuscular, intradermal, into your skin for testing. We can put it intraarticular. We can put it into a joint. If you've got a bad injury, we can put, and it's all inflamed, we can give you a steroid shot, bring that inflammation down. They can stick it in your eye. There's a new commercial for something that's intraocular injection. There's all sorts of different kinds of places we can put needles. Intrathecal, epidural, spinal. There's a whole list. But the benefit of these drugs is they're going to get into your bloodstream more rapidly than a solid dose one. They're bypassing your body's first line of protection, however, which also increases the risk of infection. So we have to make sure that people who are administering these injections are trained, they're made properly, and we can protect our patients. Now, the outcome of an injection, it's going to happen quicker. We usually can't reverse it. Once we put it in there, there's like no magic magnet we can put on the site to pull that back out. If somebody's taken an overdose of like tablets or capsules, and they haven't all broken down and absorbed into their body, well, we can get those back out. We can do gastric lavage and pump their stomach or make them nauseous or get them out before all of it gets into their body. Once that needle passes that liquid, it's it. There's nothing more we can do. The other is when we prepare them, we do need to make them in an aseptic environment, keep it clean, protect our patient from infection, and it has to be sterile. Respiratory solution suspensions apply to the mucous membrane of the nose, and then we have inhalation with microfine powder solutions, gases that go into the lungs, metered-dose inhalers, nebulizers, powdered inhalers. There's a whole bunch of different types of medications we can use. Anesthetic, or anesthetics can be administered through gas. So if you're having surgery, they have you breathe in something like Suprane, isoflurane, that will put you to sleep. A gas is going to be one of the most rapid routes of administration, although not common. Liquids are more common and most rapid in a common sense. So, picking which route of administration. Like I said before, the drug properties, how easy is it to give to the patient? Okay, if they're screaming or they're having a seizure, it may not be easy to get something into their mouth. It may not even be easy to get an injection if somebody's having a seizure. A suppository may be the easiest route to administer the medication. Everybody's going to be a little different. Pathophysiology, what disease states are going on? If they can't swallow because they've had a stroke, we can't give them something orally. We can't give them a tablet. And therapeutic objections. So some people, I don't want a shot. It could be that simple. Or it could be a religious concern as to what is acceptable and not acceptable for them. So our major routes, we have enteral, parenteral, inhalation, and topical. And enteral, parenteral, and inhalation often create a systemic effect. So it's going to go throughout the entire body. Not always, especially with inhalation, it could potentially be more localized. Topical drugs will most often create a local effect. I have a rash, I put on some Benadryl. I don't get sleepy because I use Benadryl ointment or cream. But if I have a rash and I take a Benadryl tablet, now I'm sleepy and my rash is better. So, which one are we going to pick? Well, if I got to go to work, I'm going to use some ointment or cream versus be sleepy at work. The advantages of enteral. They're safe, right? Tablets, relatively easy to use, don't require special handling, usually. Okay, one of the things about pharmacy and pharmacology, there's no absolutes. There's usually some exceptions somewhere. Don't really worry about the exceptions. Look at the big picture. Again, like I said, if they take an overdose, we can usually get the drug out if it's not too far gone. And it's usually less expensive. A tablet or a capsule, you don't have to have it made in a sterile environment. There's a special packaging and handling and all that kind of stuff. So it's going to be less expensive. Disadvantages. Well, everybody's body is different. We're going to talk a little bit more about that in the next couple of chapters. Two different people take the same medicine, it could affect them differently. It could be because one's a man and one's a woman. It could be because one is thin and one has got a little extra adipose tissue. It could be age. Their livers aren't functioning properly. One has kidney disease. There's a lot of different variables. When we take a medication orally, it goes through processes where it gets broken down in our body before it gets to where it needs to do its job. So we lose some of it along the way. So that causes lower bioavailability. The term bioavailability is just what the word says. How much is available to the body? So as a medication, if you take a tablet, let's say it's 50 milligrams, by the time it gets to where it does its work, there might only be 5 milligrams left to do the job because it's broken all the rest of it away. So that can be a challenge. And first pass, I'm going to talk more about this later, so I'm just kind of listing it right now. It'll make more sense in context. And then certain medications, well, stomach acid can have an impact. Do you take it with food or without food? Does it absorb better with or without? Certain disease states, if somebody takes, like, they've got ulcers, they're taking medication that changes the pH of their stomach so it's not as acidic, maybe medications won't break down properly. Now, your parenterals, why do we use parenterals? We don't have an oral route available. The medicine is not available as an oral because it would get broken down. Insulin is a perfect example. We don't have any oral insulin. Greater bioavailability. It's already there in your bloodstream. It's going right where it needs to go before it gets broken down. So there's going to be more of it. So that patient who got 50 milligrams of morphine orally maybe only got 2 milligrams of morphine as an injection and got a better result. Rapid onset. It doesn't have any barriers. It's going to kick in. You know, you got a headache, and I'm a migraine sufferer, right? If I take something orally 20, 30 minutes before I start feeling some relief, depending on what medicine you take. But some comes in injection and can work within 3 to 5 minutes. So it's going to be more quick with injectable. And we can control the dosage a little bit better because we know how much is going to work. We're not seeing, oh, let's try this and see how it works. Oh, now we need to up that dose because you didn't get enough bang for the tablet or capsule. You're going to learn about injections and this whole thing. I'm not going to go into a whole lot with that. Inhalation goes to the respiratory tract. Okay, if you're having problems breathing, getting drugs right there opens it up. Benefit. Some of them don't absorb or don't absorb to the same extent they would as if you took them orally or through an injection, so you get less side effects with that. And it's effective. For anesthesia, I'm going to talk about pharmacokinetics and absorption, distribution, metabolism, excretion, and things like that. With inhalation drugs, once we turn that gas off, it starts to be eliminated right back out of your body. So recovery is more rapid. Transdermal, I've already addressed that. And then topical, creams, ointments, gels, powders, it's going to be at the site. Now the boring stuff. It is and it isn't. Drug research and development. It's important to understand what's going on. I think I said the other day, or maybe I didn't, or at some point in time, because I repeat myself an awful lot. Why are drugs so expensive? So we got to pay for all the other stuff, right? So when we start with the history, research and development started back down in 1906 with the Pure Food and Drug Act and expanded in 1938, where we started seeing some of those amendments, the Food, Drug, and Cosmetic Act, which created the FDA. So the FDA, the Food and Drug Administration, started setting the standards of how do we bring drugs to market, what's safe, what's not safe. So it creates 4 levels of research or trials. We have some others. We have preclinical research. So we're in a laboratory. We're trying some things out. Maybe we're doing some animal testing. We have our clinical studies, which have those 4 tiers. Then we have a new drug application process with the FDA or an abbreviated new drug if it's a generic version. And then there's review. And one of the last steps, which isn't noted on here, but it's very important, is post-market surveillance. Because a lot of people complain, oh, it takes so long to get this drug to market. You know, we've got this segment of the population that's sick with this, and there's this drug, but they won't let us use it yet. Well, because if we let everything come to market too quickly without the proper amount of research, we won't know what are the side effects, things like that take time to develop. And that's why post-marketing surveillance is important. We have shortened the time a little bit, so drugs come on the market, but if it takes 20 years of taking this medication to see that it causes long-term damage, we're not going to know that when we first put that drug out. And we've had medications pulled off the market. We see commercials all the time. You know, a drug that sticks in my head, you guys probably never even heard of it. It was called Vioxx. It's like Celebrex, and it's in the same group. It was a COX-2 inhibitor. Because some doctors weren't paying attention to what was being told, that this drug could have interactions with certain other medications and cause like a heart attack in patients and some serious effects, they just decided to take the whole drug off the market because people aren't taking it properly. So if they're not going to do what we need them to do, we're just removing the drug. So
isn't that like a big loss for the company that?
It can be, yeah. That put all that money, time, and investment in research and development? Oh, definitely. And that's one of the challenges, and we see that with patients. Because especially once they decided that so it used to be a law that you couldn't advertise prescription medications on TV. They used to sell cigarettes on TV, but they couldn't advertise prescription medications, and now it's the other way around. They don't advertise cigarettes on TV anymore, but they advertise for prescription medications. So, oh, I have this, doctor, I want you to write this for me. And some doctors are like, okay. Or who was the last drug rep in the office? And there's been lawsuits recently about drug reps that misguided their doctors with, I think it was oxycodone, OxyContin specifically. Like telling them, oh no, this is not and yeah, it was documented side effects and things like that. So and then we're a litigious society, so it's all just kind of crazy. So this is the little schematic in your book, and it tells you the whole process. So as they're going through, they have to answer questions. If they answered yes, they get to do this step. If they answered no, they have to ask more questions. And does it make it to market or does it not make it to market? So our 3 phases being the first phase is where we give the drug to a small group of healthy people. We're trying to find out what are the side effects. So when you hear those commercials and they're like, and the side effects include nausea, vomiting, diarrhea, rash, blah, 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 blah. Those are from the healthy people who can stand to get some bad side effects that aren't really going to hurt them maybe, but could be discomforting. They're compensated. The second phase is bigger, and we use a controlled trial with patients who have a specific condition. So we say, okay, so if you have diabetes, type 2 diabetes, well, we know what the side effects are, and we know it's pretty safe. We want to see how well it treats your disorder so we can determine what's the proper dose to give, how often should the dose be given, all those kinds of things. And then they'll make that pool even larger once they kind of get those, this is the safe dosing to do and all that. They get that information, then they can give it to more patients, and they'll do blind studies and things like that. Then the 4th phase is the post-marketing surveillance. I'm going backwards. There we go. And then this is just another table to kind of look at what's going on there. So there's some legislation involved, and that is kind of the process. Questions? All right. Yes, sir.
So for phase 1, they take
healthy people
and give them, like for diabetes or low
Yep.
risk, they intentionally give more insulin, run the chance of going into a coma or something?
Well, it's kind of like, it's controlled to a certain amount. They have to sign waivers. So who do they get to do these kind of studies? College students, right?
I need money.
Somebody that wants money, needs money, yeah. College students a lot of time. So that's where we determine the side effects in a healthy person. But that's not going to give us a full picture of the medication and how it's working in treating that disease state.
Don't they need different ages?
As they really go into the others they tried, but generally a lot of the medications, some of the information, it's pretty much, we've said for a really long time that a lot of the documented information comes from a healthy 150-pound male, 25 years old. It's a statistical median, if you would. It's not the whole picture. But that's why we have the other trials in there, so that then we can break it out into, if we're going to treat Parkinson's disease, well, we don't have a lot of college-age people with Parkinson's. So we're going to have to use a clinical study group that is appropriate to that disease state. So, but that first level, you're going to use healthy people. So that hopefully it's not detrimental. But that's where they find out, does it cause you to lose your hair? Does it cause you to get an infection more easily than, all those disclaimers they put on those TV commercials. And some of them will develop over the course of the clinical trials to be more well defined in that sense.
All right. So here we are at the end of chapter 1.